Hello, class, and welcome to PTHA 2431. This is our presentation on pediatric neurodevelopment. My name is Carlos Padilla.
My name is Steven Galvan.
My name is Francisco Orozco.
And basically today we will be given the opportunity to be discussing our findings of the case study that when we went to Wagos, we had the opportunity to be working with one of the patients there. And basically what we're going to be going over is stating what she had, the developmental delays, treatments that were performed during, and also the research of such treatments that could benefit this patient in the future. I guess in the future days that this patient might be seen. Also, we have developed some videos that we're going to be presenting to you, to the class. So hopefully this can benefit.
Okay, the patient. So we had the opportunity to work with this patient, and she presented with a developmental delay. So through pragmatic observations, she presented with a decreased physical attributes and functional limitations. These delays affected her endurance and ambulation, which can practically lead to fallen trauma or risks during everyday activities. Behavioral issues were observed also during the treatment. So in addition, the PTA also reported having trouble with the patient, and she was practically combative, and non-cooperative throughout the treatment.
Patient analysis. In stance, child displays fair posture with desirable hip extension with absence of abnormalities at knee and ankle that would render orthopedic trauma. On the contrary, balance acts involving single leg stance is able to be completed for durations of 3 to 4 seconds. In addition, standing on toes requires patient to take compensatory steps in roughly 2 seconds in numerous trials. Walking. Child displays fair plus walking balance. Patient had difficulty with walking on 4-inch taped line forward and backwards as falls and loss of balance were noted. Running. Favorable speed secondary to low extremity and enthusiasm. However, stop and go on command is concluded with child taking several steps to terminate. The norms for these various activities include normal duration time for single leg stance is 4 to 8 seconds. We are expected to see normal balance during walking activities such as picking up objects while walking and turning head while walking. Normal steps required to stop are usually within 1 to 2 with minimal trials. Jumping is completed with distance of approximately 22 to 24 inches with bilateral push-off. In addition, child is unable to complete single leg hops in place or in any direction. Other dynamic tasks involving turning jumps immediate result in falls instance due to lacking in proprioception. Transitions. Child is independent with all bed mobility, including supine to sit, side to side, rolling, scooting acts. However, sit to stand, floor to stand, and bed to chair are completed with standby assistance. The child should be able to complete single leg hops in multiple directions. The child should also be adept in jumping activities, goals ranging from 28 to 29 inches in distance. Transitional activities should be done independently. So to conclude, the patient presents with favorable measurements. The patient is expected to reach goals within the following months. Her baseline measurements are not too far off of the mark of what she expected to reach, and continuation of therapy should yield the desired results. In the following slides, we'll be discussing the patient's emotional and sociological state. On site, we were able to witness the PTA try multiple approaches to take the therapy in different directions. We were there to observe him conduct his therapy on the patient, but we quickly came to the realization that the patient was not going to comply due to extreme agitation and also possibly due to the amount of people that were in the room. So once we vacated the room, the PTA was able to utilize various treatment interventions, such as using toys as incentives and general playing to elicit therapeutic exercises. The environment had to be a calming, fun environment conducive to play. According to the on-site PTA, he had been seeing the patient for over 2 months and the patient had just started becoming compliant. So through the use of his experience with children and the rapport he had already established with the patient, he was able to calm her down and continue with his therapy.
In the article that we found, talks about two kinds of behavior interventions that can help with younger kids. These kids are the ones that have some kind of behavior issues. So these methods will not affect the core symptoms, but they will teach these kids important skills later on. Some focus on strategies for staying organized and focused. These skills that are going to be taught to the children can benefit the child in the long term, skills used later on in life. This type of intervention has the benefit in the sense that some of the kids that have these behavior issues often take some kind of medication to calm them down, something like that. However, when the child stops taking the medication, the issue may arise again. So these behavior strategies have that benefit that once it is taught through repetitive, through intervention, through the treatments, the child can use it later on in life, and they will not forget it. So the first intervention group that was included in the article includes the help of the parents. These interventions are parent-child interaction therapy, parent management training, positive parent program. These interventions help parents how to use praise, positive reinforcement more effectively, as well as consistent consequences when child do not comply with instructions. The goal of these intervention is to decrease disputes and tantrums, better parent-child interaction, and reduce parental stress. Also, as per mentioned in the Umfred book, home programs are used to encourage repetitive practice to further guarantee behavior learning and increase bonding with the parents. Because a PT and a PTA can never always spend their time with the child to guarantee improvement. An additional point I would like to mention is the interaction that could be built between the practitioners, the PT or PTA, and the parents. This can grow or stimulate a growth of some sort of a team effort where the practitioner and the parents will be working together and have one common goal, and it's the child and it's the same patient. Another technique stated in the article, school interventions. Young kids with behavior issues can benefit from systems that encourage positive behavior, like the daily report card method. These approaches pinpoint specific goals for behavior in school settings, give kids feedback on how they're doing, and reward them with meeting these goals or standards successfully. The kids need to be exposed to an environment where rules and standards are placed and need to be upheld. However, rewards should be given when said child completes a task. This will teach about the importance of rules and in addition will prepare for a school environment. And going back to the first type of intervention mentioned, parents and child can plan out a planner to prepare for the next treatment time. This can further stretch the bonds, making them work together and having more interaction.
Interventions and demonstrations. One treatment to use to increase balance is using tape and lining it straight for the patient to walk without losing balance. Or basically, to start it off, the patient can just stand with feet crossed and try to maintain their balance. Both feet should always be on the line, always. So for kids, telling them to pretend that the tape is a bridge and telling them try not to fall on the lava, which is the outer area of the tape, should help motivate them as a little adventure so they could just, try to maintain their balance within the tape. And this should increase balance in a very well and fun way. Another treatment to increase, strength for lower extremity, would be kind of like a dynamic balance. Basically placing boxes on the floor and having the children jump on these boxes to flatten them out as much as possible. This tends to be more fun because it involves jumping and more dynamic experience. So you could have the patient to pretend that they're jumping like Super Mario, and the boxes should be the little bad guys, which are the Goombas, and basically they're destroying them. So involving more of a gaming situation here could make the kid more motivated and fun, just like their superhero Mario. And this should increase balance and lower extremity strength in order for their better and to increase, more of their potential effects.
All right, so here we're going to demonstrate a video presented by me, Chuck, and Steven Galvan in order to prepare yourself for a good time and to know the interventions for these children.
In our experience as SPTAs were different than clinical one working with the elderly. It required more of an upbeat attitude and using imagination from the PTA in order to work with the child. Our patient was very irritated as soon as we came in, which complicated things. The patient was hostile and we felt out of place. As students without much experience with kids in therapy, the situation was more of a challenge. We in turn felt like it would be better if there were less people in the room. We suspected that because we were males and there were 4 of us, that it in turn made the patient more emotional and then made therapy impossible. After one of our female classmates entered, she seemed to calm down, but then reverted to her previous state of agitation soon after. It got to the point where we had to observe the patient from an area where we could not be seen so that the therapist could do his work. This patient was very agitated, which made it difficult to work with her, but it also gave us the opportunity to witness how some patients can be more difficult to work with than others. And it is our job to find out what would be the best and most appropriate approach for such patients. Although we only worked with our patient for a limited time, we can see how different children react, what type modifications are needed to be done for exercise, and their type of neurodevelopment behaviors.